announcements made, I would like to welcome everyone to today's webinar. Today's webinar is titled Connecting Older Indians to Benefits and Greater Economic Security. Our presenter today is Brandy Bauer. Brandy works with community organizations and state agencies across the country to promote benefits for older adults, identify strategies to improve the financial security of vulnerable seniors, and disseminate promising approaches to maximizing benefits, outreach, and enrollment. Brandy has 17 years of experience in communications related to improving access to health and human services for vulnerable and marginalized populations. I will now turn the presentation over to Brandy.
Thank you, Julie, and thank you everyone for joining me this afternoon. I'm going to start off by giving you a little bit of background about the National Council on Aging, which I represent, before I delve into a profile of elder economic insecurity, and then talk about specific benefits programs that you can connect your elders to, as well as resources that you can use to connect your clients and participants in your program to these benefits. So just to get started, the National Council on Aging is a nonprofit service and advocacy organization that has been working for over 65 years to help people meet the challenges of aging. We really work in three main areas. We work around economic security to help individuals access benefits, seek training and employment opportunities, and also find other community resources that can help them maintain health and independence. We also work in the area of health, in managing chronic diseases and preventing falls. And then finally, in public policy and advocacy, to advocate for programs that can help support older adults to stay living in their communities. Within the National Council on Aging is the National Center for Benefits Access. This is supported through a grant from the U.S. Administration for Community Living, and we have as our mission to help community-based organizations and state agencies find and enroll seniors and younger adults with disabilities into all of the benefits programs for which they are eligible. So let's get started on the whole topic of elder economic security. A lot of the safety net programs that are out there and have been out there for many years, such as Social Security and Medicare, have done a tremendous service to older adults in helping to reduce the poverty rate. However, there is still significant elder economic insecurity across the country. And just to give you a little bit of current sort of state of affairs, one of the things that we are seeing among older adults is rising debt. Debt among older adults has grown significantly in the past decade. And when we surveyed our network of aging professionals who work with low-income seniors, we found that medical costs are a major source of that debt. This is particularly true for all populations, but especially those with chronic conditions. And as you'll see here from census data, only 28% of older Indians rate their health as either excellent or very good, and many of them have multiple chronic conditions. And as you know, managing multiple chronic conditions means often having to go to the doctor more frequently, having to pay more for medications, all of which have costs associated with them. Something we've also found with debt is that the amount of debt that seniors are carrying has grown significantly as well. The median household debt for seniors in 2013 was just under $41,000, so a very significant amount of debt. And many older adults are retiring or being forced to retire without any savings to help them out. We also know that about 25 million adults who are over the age of 60 have incomes below 250% of the poverty level, which is roughly $30,000. But Indian elders are more significantly likely to fall within the poverty levels. You can see here that Indian elders have higher rates of poverty when compared to just general senior population, 17.5% versus 9.5% overall. And on average, those who are drawing Social Security earn about $1,000 less in benefits each year compared to the non-Indian older adult population. After this webinar, we're going to share some links with you, and one of the links that I'm going to share is for a tool called the Elder Index. And this is a tool that was developed a few years ago that enables you to really delve deeply in your community to understand what it takes to be economically secure as an older adult. It looks at things like the cost of food, the cost of transportation, housing, and average medical expenses to provide a numeric point to sort of see what the threshold is for being able to sort of stay financially independent in your community. So I encourage you to use that tool after the fact. Before I talk about some of the specific benefits that are available for older adults, I want to just do a quick survey. We've got a lot of people on the line. I wanted to see how many of you are familiar with some of these different programs. I'm going to talk about each of them, but just to get a sense. So I'll give it just a moment as you all have a chance to answer. And it's not surprising to me that Medicaid is the most well-known. I know a lot of you probably work in the healthcare sector and are quite familiar with Medicaid. Some of these other programs you may be less familiar with. So I'm going to go ahead and we'll end the poll. Okay. Thanks, Julie. So basically at NCOA, we've sort of categorized these core benefits as what types of programs can really help low to moderate income seniors achieve economic security. And of course, along the lines of healthcare, there's Medicaid, as most of you are familiar with, the Medicare savings programs, which some of you seem to be familiar with, but I will go into. To help pay for prescriptions is the Extra Help program, which is sometimes known by the acronym LIS, which stands for Low Income Subsidies. For food, there's SNAP, as well as a host of other programs, such as Meals on Wheels benefits, commodity supplemental food programs. And then utilities, we have the Low Income Home Energy Assistance Program, or LIHEAP. And I'm going to be talking about each of these in detail in just a moment. First, starting with the one that you all know, I don't really need to go into too much detail about this, other than to say that roughly 9.9 million, just under 10 million people in the United States are eligible for both Medicaid and Medicare. You'll sometimes hear these people called dual or dual eligible, and you should know that people can have both programs and that Medicaid will pay for some of Medicare co-payments and cost sharing. Essentially, Medicare usually pays first, and then Medicaid pays second, and we call it kind of wraparound coverage for this population of duals. Unfortunately, I don't have a lot of data by ethnicity or race on the duals population. The federal database only looks at white, Black, and Hispanic, so there's roughly about 1.4 million people who get categorized as other, who could be any number of either older Indians, Asians, that sort of thing. What's important to know is that anybody who does get both Medicaid and Medicare will automatically get the Part D low-income subsidy or extra help, which I'm going to talk about in just a moment. Then there's the Medicare savings program. This is a little bit confusing because Medicare savings programs help to pay for Medicare, but they are financed by Medicaid, and they are administered by the state Medicaid agencies. They really help people with low income and resources pay for their Medicare premiums, as well as cost sharing for those who have very low income. You may have heard of these programs by their acronyms, QIMBY, SLIMBY, and QI. And the difference between the three of those programs is just the income level at which you qualify. So QIMBY is the most generous of the three programs for individuals who have income below 100% of poverty, and it covers Medicare Part D premiums, deductibles, co-payments, And if somebody does not have enough work credit under Social Security to get Part A for free, Quimby will also help to pay for any Part A premiums that person might have. The SLIMB and QI programs only cover the Part D premium of roughly $120 a month. And it's usually up to 135% poverty that somebody can qualify for either of those. However, because the Medicare savings programs are financed by Medicaid, states do have a lot of influence over how the programs are administered and the eligibility rules. So states often can be more generous than the federal eligibility threshold by either lifting those thresholds, or even there's an asset test as well. So people have to have resources below, $7,000 or $13,000, depending on if you're single or married. And states can choose to eliminate that asset test. And again, if anybody qualifies for one of these Medicare savings programs, because they're considered part of Medicaid, they will automatically get the next benefit, which I'm talking about, which is the Part D Extra Help, or LIS program. So Part D, Low-Income Subsidy, or Extra Help, is administered by Social Security and Medicare, and people apply for this program directly through the Social Security Administration. The Extra Help program helps to pay for Medicare Part D, as in drug plan, costs for people with incomes generally below 150% of poverty. And what this does is individuals will get an amount that will pay for their Part D plan premium up to a benchmark. And the benchmark is just generally what's considered the average cost of a drug plan in your area. Nationally, that's about $34, $35 a month. So it'll pay for that premium up to that amount. And then people, when they go to the pharmacy and they have Extra Help, they will pay usually between $0 and $8 for a copayment for their drug. $8.25 is the maximum that they would pay in 2017 for a high-end brand name drug at the pharmacy. The Extra Help program eliminates what's called the donut hole, or the Part D coverage gap. You may know about this. This happens when somebody spends, in 2017, the threshold is $3,700. When they spend $3,700 on total drug costs, they enter what's called a donut hole, which means that they are responsible for a greater kind of cost sharing of their drugs until they reach what's called the catastrophic coverage period, spend a little over $7,000. If you qualify for Extra Help, you do not experience this donut hole at all. You're always going to have, your drugs covered for this very low amount of money. Another really great thing about this program is you can switch your Part D plan at any time. You don't have to wait for the annual open enrollment period in the fall. There's a guaranteed special enrollment period. So if somebody has Extra Help and maybe they are diagnosed with a new chronic condition and suddenly have to start taking some more medications, and those medications are not on their current plan formulary, they could go ahead and switch to another plan and not have to worry about that. There's also no late enrollment penalties, and this is a big one too, because a lot of people don't know about Part D and don't necessarily enroll in it when they turn 65, and if they don't enroll when they're first eligible, they can face this late enrollment penalty for the rest of their life. But that doesn't happen to people with Extra Help. That is completely waived, and they will never have to pay that late enrollment penalty so long as they continue to qualify for Extra Help. So it's a great benefit. SNAP, I think a lot of you indicated that you are familiar with. You also may hear of this still referred to as the old name food stamps. It's also got different names in different states. But SNAP provides monthly funds on an electronic benefits transfer card to spend on food at qualifying grocery stores and farmers markets and farm stands. The eligibility criteria varies widely. At the federal level, they set the threshold for older adults of 100% of the poverty level, but states can, because it's administered at the state level, can choose to raise that. And older adults, for the SNAP program, that means you're over 60, and persons with disabilities can get a higher benefit amount if they have high out-of-pocket medical expenses in excess of $35 a month. They'll have to prove what those expenses are, and a lot of times they will bring in receipts. But that helps to increase the minimum benefit that they get. As a general rule, people often we hear at NCOA that people don't like to apply for SNAP because they're only going to get $15, and that $15 myth is very broad, because that is in fact the minimum benefit. However, we know from data that has been released by the Food and Nutrition Service that the majority of older adults who get SNAP get a lot more than $15. Only about 18% nationally get that minimum benefit. The average benefit is about $108 a month. And with that out-of-pocket medical expense deduction, people can get a higher benefit. So we really encourage people to look at their state application to help people that they're working with to apply for SNAP, because it's a worthwhile benefit. Even though some people may perceive it as being minimal, it's still a very worthwhile benefit. And then the final core program that I wanted to mention is the LIHEAP program, which is the Low-Income Home Energy Assistance Program. It's sometimes also just referred to as SEEP. This is slightly different from the previous programs that I mentioned because it is administered as a block grant to states and territories through the U.S. Administration for Children and Families, which means that once the block grant is expended, there is no more money. And therefore, there's often very, very short windows of time in which people can apply for those grants. Most of the funds in cold climates are expended in the winter. So often the state LIHEAP program will have an opening of like a 2-week window in October or November where families can apply, and then the money is gone. Most of the funds are administered locally through what are called community action agencies. And the LIHEAP program will either be paid as a grant directly to the energy or utility company. Sometimes it'll go directly to the household. And the grants will be used to pay for things like heating costs, cooling costs. Sometimes they can also be used for things like insulation, improving exposed water pipes, replacement of heating and air conditioning units. It really varies by state. In most states, the household can qualify if the income is below 150% of the poverty level. And LIHEAP has a very specific mission of trying to find the most vulnerable households. So they really look at households with an elderly member or households with young children. Those are priority areas for funding and providing grants for those individuals. Why do I mention these benefits programs in the context of economic security? As you'll see on this slide, each of these has an average value, and this value is calculated usually by the agency that administers the program. So, for example, for the low-income subsidy, the Social Security has said that the average value of that benefit, if somebody qualifies for it, is roughly $4,000 a year. Now, not everybody is going to get all of these benefits, but you can see here that even getting one or two can add a significant amount of money back into the household budget. And were you to qualify for all 5 of these programs, you could likely, save over $12,000 a year. So significant impact on people's budgets, especially people who have incomes very close to the poverty line, which is roughly $12,000 a year for an individual. So I'm going to talk a little bit about some of the resources out there that you can connect with to to help your clients or people you work with to find these benefits. And before I do so, I wanted to ask about whether you've used any benefit screening tools. And I'm being purposely generic in this question. Some states have their own screening tools. Some programs have their own screening tools. And I'm going to share with you some screening tools that the National Council on Aging has developed. I'll give it just a moment here. Okay, Julie, I think we can close. So it looks like roughly half of you have used some benefit screening tools and half of you have not. So I'm hoping that I can provide those of you who may not be familiar with some resources. BenefitsCheckup is a confidential online screening tool that NCOA, my organization, developed a little over 15 years ago. And this is a web-based tool. It contains over 2,000 public and private benefits, including all of the programs that I just mentioned, as well as a whole range of other programs. For example, we also have property tax relief programs, local transportation benefits, veterans benefits, state cash assistance programs, programs from drug companies, which are called patient assistance programs, which can save money on specific brand name drugs, other food programs, caregiving, dementia assistance, volunteerism, lots and lots and lots of different categories of programs. You can see there that we've helped over 5 million people find more than $17 billion in benefits since the tool was first developed. But the way it works is an individual can go onto the site and can enter in some basic information about themselves. We've just redesigned this site, so some of you who may have seen it in a previous iteration will be pleased to know that the newest design allows for you to search by specific program. So, for example, if you're working with somebody and you know they already have Medicaid, you know they already have SNAP, but maybe they're interested in looking for some housing and utility assistance, you can just look at those programs, and you will only get a screening tool that asks questions related to those programs. So what will happen is the individual it'll ask for a zip code, and that narrows down the program to the specific geographic area. And then there will be a series of questions related to income and expenses. How much do you get in Social Security or, earning? How much is your gas bill? How much do you spend on food, if that's related? And then each person will get a personalized report that contains fact sheets about each program. So the fact sheet will say, this is what this program is, this is how it is administered, this is where you need to go to get an application. A lot of the programs have applications available to download or to do online, and if that's true, then it's also within BenefitsCheckup. You'll find that information, as well as information on local offices and maps to find out where you want to submit the application, get more information, and documentation that is needed. So if you are going to go to the local social service office, it'll say, here's what you're likely going to need to bring with you. It's completely confidential to do a screening on BenefitsCheckup. A person can get and download a personalized report, but we do not save any, and there's no sort of personal identifying information that we save or, contain about the individual. So it's perfectly safe. Another thing I wanted to mention is that we do have on this tool, you don't have to do a screening to use the resource library. You can go onto benefitscheckup.org, and there is a little tab for a resource library, and you can just get basic information about the types of programs that are in your state. So you can look and see if I live in Montana and I'm just looking to see what's there for food and nutrition programs. You can get a list of those very easily just by looking in our resource library. So again, if you've not used BenefitsCheckup or if you've used it and you haven't used it recently, we really encourage you to go and play around and explore and see if it's something that you could use with your clients in the future. Some more information about places that you can help connect people to related to these programs. Some of you may be familiar with the SHIP. These are the State Health Insurance Assistance Programs. They do go by different names in different states. So, for example, in California, they go by HICAP. In Massachusetts, it's called SHINE. In Missouri, it's called CLAIM. But what they are federally funded organizations that provide free and impartial advice about Medicare to people with Medicare and their families. The SHIPs also do application assistance for the Medicare Savings Program and the Part D Extra Help Program. And they do receive grants at the federal level to do that. They do a wonderful job doing that, and they can provide a lot of information and screening for those specific programs in your area. You can find your local office by contacting the SHIP TA Center. You'll see the website there. They also have a toll-free number that you can call and get connected to your local SHIP office. You can also look at other local aging organizations, such as area agencies on aging, aging and disability resource centers will often do benefits assistance. If you're not connected to those already, the Elder Care Locator is a service of the U.S. Administration on Aging, and they have, again, a website and a toll-free number that's open from Monday to Friday that you can get a direct, what we call, warm referral to your local aging agency. And then I'm going to talk in more detail about what are called benefits enrollment centers, and this is a network that is supported by NCOA. So, benefits enrollment centers. As part of a grant that we received from the Administration for Community Living, the NCOA Center for Benefits Access began to establish these benefits enrollment centers throughout the country beginning in 2009. We now have a network of 59 in 31 states. And what the BECs do is to use what we call person-centered strategies in a very community-wide coordinated way to find and enroll low-income Medicare beneficiaries and get them into all of the core benefits that they're eligible for. So that what we mean by person-centered is making it easy on the individual to go kind of one-stop shopping to find out if they're eligible for all of these different programs and then to get assistance applying for all of them. So the BECs, it's sort of soup to nuts. They assist not only with the screening and the outreach, but with the application itself, with troubleshooting any of the problems with the application, as well as following up to see whether the person receives the benefit, knows how to use the benefit, and also recertifying for the benefit, because many of these programs require some sort of ongoing verification that the person is still eligible for them. The BEC grantees do provide screening and enrollment. We require them to screen and enroll for the core benefits that I talked about earlier, the Extra Help Program, the Medicare Savings Program, Medicaid, SNAP, and LIHEAP. But they have the option, and they all do, connect individuals to a wide range of other programs, such as state pharmacy assistance programs, veterans benefits, the Supplemental Security Income Program, tax relief, housing. If they know about it, they work on it. What does a BEC look like? This is a question we get a lot at NCOA. And are they actual physical places where people can go? And the truth is that the model varies. A couple of our benefits enrollment centers operate a call center model, and therefore they do their application assistance entirely over the phone. Most of them, however, do have some form of in-person assistance. For example, one of our benefits enrollment centers in New York City has what they call a storefront operation, where anybody can come in from the neighborhood and get assistance. A lot of these benefits enrollment centers outstation counselors at specific sites. So they go to senior centers or libraries or federally qualified health clinics, any place where they might have a relationship and know that there are a lot of seniors that congregate, and they will do their sort of outreach and assistance at those places. The benefits enrollment centers are either nonprofit community organizations or state aging agencies. A lot of them operate benefits assistance within the context of a broader mission related to kind of alleviating poverty or helping with health and human services. So, for example, we've got a couple that are hospital systems. We've got quite a few that represent ethnic communities, and a couple food banks. There's really a broad diversity of types of organizations. Most of them serve specific targeted cities or regions within their state. However, a few of them are statewide. And as I mentioned before, there are 59 benefits enrollment centers currently serving individuals in 31 states. And what does this look like? Here is a map of our current benefits enrollment centers. You may be wondering why some of those dots on the map are only red and several of them are multicolored. And that is because the multicolored dots represent benefits enrollment centers that also do some other program with NCOA. For example, some of them participate in our chronic disease self-management program. Some of them work specifically on our economic security initiative, or we also have a separately funded SNAP initiative. I think I see somebody saying Alaska is not on that map. And the reason is that we unfortunately do not have a benefits enrollment center in Alaska or Hawaii. So I'm sorry to say, but we certainly encourage people to, hopefully we will continue to receive funding to support these. We would love to have at least one in every single state. So if you work for an organization that's doing benefits assistance, we would love to hear from you and sort of keep you posted on that. I bring up the benefits enrollment centers because I know a lot of people on this call probably work within a diversity of settings. Some of you may work for community health clinics. Some of you may work in specific tribal programs. But the BECs are there to collaborate with you. They're not trying to take your business. They're really trying to support the effort to help these vulnerable older adults and younger adults with disabilities to really connect to programs that can keep them financially sound, living independently in their communities, keep them healthy, eating nutritious food. So we really would love for you to explore partnering with the Benefits Enrollment Center in your area. That can take many different forms. It could be simply making a referral. So if you work, for example, at an F2HC and you get older adults and maybe you help them with Medicaid, but you know that they probably qualify for SNAP or LIHEAP, and there's a Benefits Enrollment Center in your community, you could make that connection and make that referral over to them. You may also want to do joint events and outreach. A lot of our Benefits Enrollment Centers do health fairs and other types of activities. A lot of them are also very much interested in reaching pockets of vulnerable older adult populations, such as older Indians. And so if you know that you're going to be doing some sort of a community event and would like somebody representing the kind of benefits angle, you're certainly welcome to invite them to be part of that. And then finally, mutually sharing best practices in reaching Indian elders. We hear a lot from the Aging Network that, they really try to make inroads to reach older Indians, but they're not necessarily successful. And so if you have best practices that you can share with that network, we would love to profile that and make those connections for you. And so I include this thing. Please do not hesitate to contact the National Council on Aging to sort of get connected to these benefits enrollment centers. We do actually have on our website a contact list, which has the primary contact at each of our benefits enrollment centers, and that you could use to go ahead and make that connection, as well as their service area. So you could find out easily whether you're in a service area that a BEC is in and whether it's worth making that connection. Before I open it up for Q&A, I just want to point out a couple of additional resources. The Kaiser Family Foundation released this issue brief, which talks a lot about Medicaid and the American Indian and Alaskan Native population. It's a great resource, and one of the things that they really point out is the fact that the Affordable Care Act has helped to boost coverage for American Indians, especially that gap that we see of older adults who aren't old enough to start receiving Medicare, but may not be working, that kind of 60 to 64 population. They have some great numbers and information about that. Most of you are already familiar with the National Indian Council on Aging, NACOA. They do wonderful work. They have a wonderful website full of great resources. We encourage you to connect with them as well. And ACL has an Office for American Indian, Alaskan Native, and Native Hawaiian programs that's also excellent. Cynthia LeCount is fantastic, and they, too, are a fantastic resource, have a lot of statistical information about the older Indian population, and maintain a list of grants that are available to serve this population. You are certainly welcome to explore NCOA's website. As I mentioned earlier, we have a follow-up email will go out after this call, which has a listing of some of the key resources that I talked about. But we certainly encourage you to use them and to share them. I have left my contact information on there, so if you have any questions about anything in this presentation, you're more than welcome to contact me. And I see several questions have come in, and I think I will turn it over to Julie.
Thank you, Brandy.
We can start the question and answer session.
Thank you, Brandy. This is our time for you to ask questions of Brandy. Please enter your questions in the Q&A box located at the bottom right side of your screen. And we do have a couple of questions that have come in. Brandy, one question is, does the dual qualifications vary by state?
That's a very good question. And yes, and the reason for that is that while Medicare qualifications are at the federal level, you qualify based on age or disability. The Medicaid qualifications do vary by state, and so therefore it would depend on what the Medicaid rules are in your state.
Another question.
And then, I see another question here, which is which we get all the time, and actually it varies by program. It was asked, what is considered elderly for these benefits? And the truth is, it varies by program. For the SNAP program, older adult or elderly is anyone age 60 and above. I believe that is also the same for the LIHEAP program, the Low Income Home Energy Assistance Program. Obviously for the Medicare Savings Program and the Extra Help Program, they are connected to Medicare, so it's less about age and more about Medicare status. Therefore, most older adults with Medicare are over 65. However, people can qualify for Medicare based on disability, and therefore they can be at any age. So for those programs, it would be based on your Medicare enrollment status. Oh, this is a very good question about dialysis patients. Can dialysis patients qualify? That is a wonderful question because, as some of you may know, Medicare people can qualify for Medicare based on a couple of different factors. They can qualify for age. They can qualify if they have received Social Security disability for more than 2 years, and they can also qualify if they have end-stage renal disease. And the rules around end-stage renal disease are very different because, what parts of Medicare are covered and what are not, and therefore not all of the Medicare benefits that I talked about today apply for that. We have some specific information that was developed for us on end-stage renal disease and dialysis patients. That's on our website. So I encourage you to look for those. You can just type in ESRD on NCOA.org and find more information about those rules of those programs. I'm just scrolling through here.
Brandy, one question that came in is, if a low-income senior owns a rental property providing most of their income, does the real estate asset disqualify them from programs?
It will depend on the program. A lot of times with a rental property, it is considered earning, so they would have to report those rental earnings and the net that they get from that rental kind of profit. So it really depends on the program, but yes, they would have to report it, and it would really depend on the amount of rent that they're collecting from that. I see a question here about Medicaid waiver clients. There are hundreds of Medicaid waiver programs across the state, and it would be difficult for me to really contain those in a presentation like this. However, I will say that in BenefitsCheckup, we have most of those Medicaid waiver programs listed. And so, therefore, if you're looking for specific information on those programs, we encourage you to use that tool. A wonderful question here about how long does the process take for applying for these programs and what documents are needed? That's a very good question. I will say that for programs like Extra Health, which are administered at the federal level, there is a 45-day turnaround time, but it's often quicker that a determination is made. For programs that are administered at the state level, it varies. Many of them are supposed to turn around an application and make a decision within 30 or 45 days. We have heard that there are some states with significant backlogs of a couple months. As far as documentation, if you use BenefitsCheckup, it will tell you a lot of the good documentation needed, and it depends on the program, but usually needing to verify income information, asset information, such as if a person has savings accounts or stocks or something like that, approximate value of assets, if an individual has that, and medical expenses. So a lot, because there's a lot of information about medical expense deduction, especially for SNAP. You would want to have information about your average expenses that you're paying for medication. Somebody asked what the website is again, NCOA.org. And there's a couple questions here about IHS, and I do want to address that. And you're correct that many older Indians do use tribal or IHS Health Clinic Pharmacy. And one of the things, obviously, that Medicare and IHS are kind of different systems of care. So it's a fine line. If you're working with people who are, they live in close proximity to an IHS healthcare clinic, they get all of their services from there. Obviously, you need to weigh very carefully. Do they need Medicare? We always encourage older adults, if they qualify for Medicare, to take Medicare, because you never know when you're going to, not be close to an IHS facility. And another thing, too, is that it saves money for the tribe, especially if the individual qualifies for these programs, which make Medicare not free, but that pay for their Medicare premiums, and they don't have to have that responsibility, then they're able to see other providers and thereby kind of reduce the sort of charges specifically for the IHS facility. Somebody asked about whether using the IHS Pharmacy would affect the donut hole, and it's probably because it's not going to be, the Part D plan isn't going to apply at the IHS Pharmacy. Then the money that is spent at the pharmacy is not going to apply towards the overall out-of-pocket costs and the donut hole. I hope that made sense to those who were. Another person asked, what would a veteran qualify for if they don't have the required 40 credits? Good question. Again, there are specific programs for veterans that are run through the Veterans Administration, and as well as Veterans Benefits Administration. However, an individual, irrespective of whether they're a veteran or not, if they don't have the required work credits for free Part A in Medicare, they still might be able to get the Medicare Savings Program to pay that Part A premium for them if they qualify for that. So it's worth looking into that. Oh, and somebody asked about 2 years of receiving Social Security disability. Yes. So the disability requirement for Medicare is, Medicare is kind of administered partially through Social Security. So if an individual is receiving SSDI, the Social Security Administration knows when they have hit that 24-month or 2-year mark, and they will be automatically enrolled in Medicare. So they don't have to do anything to actively apply right after that 2-year mark. Social Security will know, will send them a welcome packet, and then they will be automatically enrolled in Medicare then. A clarification on an earlier issue about the second home. The real estate itself, usually a person's first home is exempt from any sort of asset test. The home you live in, your furniture, your sort of day-to-day necessities are all exempt. But if somebody actually owns multiple properties, then those sort of second or third properties would be subject to looking at the value of that. And it might disqualify, but you never know. It depends on if the program actually looks at assets. So a couple of people just asked, is this, are we talking specifically about Indian elders? One thing that I will say to you is that all of these programs are available for Indian elders, and there are very specific rules related to a lot of the federally and state-funded benefits that go to Indian elders. For example, money in trust, certain payouts that Indian elders may receive are not counted as assets, so they're not kind of held against the individual. So that's something to be aware of if you're helping your older Indian clients apply for these. There's a lot of those special payments that are based on their Indian and tribal status will not be counted as assets, that is therefore not held against them in looking at their income and assets. Is there a BEC certification course available? What we have on our website is we have what's called an assessment tool, which helps you to sort of look at your organization if you're interested in a sort of becoming a benefits enrollment center. You can take this kind of little self-test to sort of see if you're ready, if you're doing the work. We don't do a certification. However, whenever we fund benefits enrollment centers, we do have a proposal process, and there is, you would have to respond to specific questions about the benefits that you're helping, the population that you're helping. I see a couple. Let's see. I see a couple of these questions that are very specific questions about what's called estate recovery and married but not living together, and I don't have an immediate answer for you. I think a lot of these, it depends on the program and it depends on the state that you live in. And I would certainly welcome responding to those questions sort of offline and doing a little more research to help you out. Again, somebody asked about enrolling a client due to Indian trust lands. I'm not sure specifically in your state or which program you're trying to enroll them in. You mentioned institutional care. Usually, Indian trust land is not counted for the major programs like extra help in the Medicare savings programs. I am not sure about your specific institutional care, though, so I would have to look that up for you. And yeah, let me clarify one more time. Somebody said, did you say Native American per capita monthly benefits weren't counted in eligibility? For a lot of these programs, those special funds that go to Indians are not counted. That's not to say that every single program doesn't count it, but for a lot of them, particularly for the ones related to the Medicare benefits, those types of benefits are not counted. So, Julie, it looks like the questions that I have here are sort of more very specific that I would need to do research for. So I don't know if anybody has anything that's a little more broad.
Again, if you have any questions for Brandy, go ahead and enter them into the Q&A box at the bottom right-hand side of your screen. And it is getting closer to the top of the hour, so we will just take a few more questions. Okay, if there are no more questions, then we can go ahead and conclude our session. If you have any follow-up questions, you can reach out to Brandy at brandy.bauer@NCOA.org, which is brandy.bauer@NCOA.org. And thank you, Brandy, for your time and sharing information about benefits available to elders. In closing, I would like to remind everyone that today's webinar was recorded and that the audio and PowerPoint will be made available online at cms.gov. Thank you again for joining today's webinar. Our session is now concluded.